Coming up in this episode, at what point, at what age, and with what assessments can we determine if someone is ready to run or someone is too old to run?
As we grow older, our body generally is not as strong as it used to be before. It's important to have a strength and conditioning program that you focus not just on mileage and running the distance, but also at the same time complementing it with ensuring that your muscles are strong enough to handle the increased load and mileage that you're putting on it. I don't think there's one perfect way of running. I don't think there's an ideal shoe for any runner. If you answer yes to any of those questions, you need to see one of your doctors to ensure that you are fit enough and definitely medical condition that would put you at a higher risk of getting problems when you run. I don't think the verdict is really out there that running leads to arthritis. I think it's a balance, as in most things in life. But finding that balance is the million-dollar question. I mean, having said that, like those ultra marathoners, like, they still run no matter what. Like, primary arthritis is something that happens without any known cause. There are a lot of factors that come into play when we talk about the best treatment option for the patient. I find sometimes that it's not very fair for patients to be paying so much and expect that the supplements that they take are really as good as they make it out to be. I mean, I have patients who have gone back to their previous level of sports. I think you're never too old to start running.
Hi guys, welcome to another episode of Geeks podcast. In this episode, I have with me Dr. Foo Gen Lin.
Hi guys.
And we're going to talk about old age, running, as well as arthritis. For that, just a quick update. Two quick things. Firstly, while editing the video, I realized we have past videos giving more context to some of the topics we discuss in today's episode. Check out our playlist on running to find out more. Secondly, ALLSET will be launching a sports and healthy aging lab next year. Stay tuned to our channel and subscribe for more updates. With that, let's get started. Hi Jen, firstly, thank you for your time.
No, thanks for having me.
First question to you is, as a trainer, I have clients that come to me because they want to pick up running in their 40s as well as in their 50s. I also have clients who are in their 70s and 80s, and I do think that running might not be as good for them, or they need to get stronger to get started. At what point, at what age, and with what assessments can we determine if someone is ready to run or someone is too old to run?
That's a pretty big question to start the conversation going, but I think you're never too old to start running. I think when you start running, you first need to ensure that your health allows you to run. We have a set of questionnaires based on the PARQ questionnaire that allows you to assess whether you have any conditions that would mean that you are slightly at a high risk for running. So if you are eligible or there's no contraindication based on the PARQ, normally the doctor will help you through the process of getting you to running. I think in terms of getting to running, you need somebody who is able to advise you on your health. So normally you can speak to your doctor about that, or if you have a running group or somebody who runs, they can usually share as well, like how you start running. I would normally advise patients that if they are fit to run, they start slow. As in anything in life, you need to start at a slow pace and move up gradually to reduce the risk of injury. And again, people come to me from different backgrounds. They might have experience running, or they could be on the older age group. But generally speaking, if they are good enough and well enough to run, I would advise them to start with brisk walking. And if they're able to walk for like 30 minutes of brisk walking, they can progress to jogging. And if they can do that, they can gradually move up to running. So that's the very stepwise sequence of how to get into the sport of running. And again, it could be a whole topic of running, because there's so many things that you consider about shoes, consider about equipment to run. But just having a group to begin with who can provide advice on what to wear, how to run would be a good point to start running.
Speaking of the PARQ, what are some of the questions that you ask?
I don't have the exact specifics, but some of these things include like, do you have any chest discomfort when you run? Do you feel breathless when you perform any physical exercise? Those are probably things that you need to work out. If you answer yes to any of those questions, you need to see one of your doctors to ensure that you are fit enough and do have any medical condition that would put you at a higher risk of getting problems when you run.
How do previous injuries play a part in determining whether you are fit to run at your current age or your current stage?
Yeah. Again, I think there's such a diverse range of people to go into running. If you have lower limb injuries like knee injuries, ankle injuries, that will probably put you at a higher risk of developing an injury if you go into running. I would advise, again, as per my previous question, that you should start slow if you haven't run for a while and see how it goes. If you find that the old injury comes back in again, you have pain, I would recommend seeing a doctor to ensure that the injury that you had before is treated before you attempt to go back to running again, and to ensure that there are things that we can do to reduce that risk of the injury flaring up in the future.
Speaking of injuries, are we more injury prone as we age? What are some things that come with age?
I'm 40 years old this year, not super old in the grand scheme of things, but I'm definitely feeling it. As we grow older, I think our body generally is not as strong as it used to be before. And we also undergo a degeneration in the joints. So those two combined would potentially put you at a higher risk of injury when you start any sports, not just running, but any sports in general. And those are the things that we do mindful of, especially when you start a sport at the later age, which is why I think having someone to guide you through the process and having someone to help you get stronger, to watch what you wear in terms of the shoes, and also to ensure that you don't have any injuries that can arise from any of those things like weakness and degeneration that can make running difficult for you.
On that point, one is about some advice on shoe selection. The second one is, what are some musculoskeletal injuries you get when you run?
Okay. Well, getting two very big questions.
Yes.
Yeah. So I think shoe selection, that's another big topic in itself. You can talk to the cows come home about what's the best shoe for you. I don't think there's an ideal shoe for any runner. And there are such a huge range of shoes out there that I think sometimes when you're starting out running, you really get quite lost in the whole scheme of things. What I advise would be to go to your local running shop. There are a few in Singapore. I mean, I'm sponsored by Hawker, but I'm not promoting any one particular store. But some stores like Running Lab, where they have a treadmill, they have usually a very helpful staff who can take you through the process. So the selection process starts from looking at your feet structure, your ankle structure, to see if you have a flat foot, to see if a high arch. And there are different shoes in the market that cater to your foot type. And the specialist at the shop, will be able to help you through that. And there's a treadmill for you to try on those shoes and just to find one that you feel comfortable in to run. I understand that you probably talk about barefoot running because that's another big topic that was in the running community about 10 years ago when I think the book Born to Run was talking about how we should go back to basics, run like the way we used to run without shoes. But again, I don't think there's one perfect way of running. There are two different camps. Like one is the forefoot runners and the rear foot runners. The majority of us are rear foot strikers, so we land on our heel first. The proponents of barefoot running were suggesting that we try to wear shoes that are minimalist, very thin soles, that kind of puts us back to being more careful about not striking with our hind foot, but more on the forefoot. But it's also can be a problem because we're not used to that, and we transition very quickly from being rear foot runners to forefoot runners. That can be problems too. So in a nutshell, I think that if you have been wearing normal shoes and you've been running rear foot, running all this while, and with no problems, I would probably just leave it as this and just stick with it, because I'm also a rear foot runner and I have no problems touch with so far. Haven't really converted to the whole minimalist shoe group, but it is an option if rear foot running hasn't really been that great for you. Actually want to try something else that could work for you. So I would suggest trying the minimalist shoes for that kind of running. But overall, just look for a shoe shop that has a very helpful person to take you through the process of choosing a shoe that works best for your feet. And just take it from there. Second question, sorry, I forgot about the second question. But you're talking about, I'm too excited about shoes.
The second question is, what are some injuries related, MSK injuries?
Wow, that's another really big question. Tends to be overuse injuries. So I remember when I started my running journey, the common injuries tend obviously to be your lower limb injuries, like leg injuries. So I was struggling a bit with shin splint when I first started running. Shin splints is also medically called like medial tibial stress syndrome. This is when we suddenly go into running and it's a high impact sport, and your body structure is trying to get used to the load that you're putting through your body. And it happened to me because I think I came from a swimming background, so it's very low impact. And going to running, having not done much of that and just stepping up my volume very quickly, the body was trying to adjust to that additional load, and it was painful the first few weeks, but I had a really good coach who took me through the process of taking it a step back and trying to increase my load gradually over time. I remember I was in the cross country team at the time, and I was just really new to the sport and just thought that mileage was everything. So I think that was probably the reason why I developed shin splints. So very common injury, shin splints is one of them. And the treatment normally is just prevention rather than cure. But if you ever have that, like just to take the training a notch down, watch your mileage, and when you go back to running again, just start slow and gradually increase your intensity and your mileage. The other problem that's also quite common is Achilles tendonitis. This is where you have pain at the back of the heel around Achilles tendon. Again, tends to be overused. So I had it sometimes when I step up my intensity too much too quickly. And again, the treatment for that is prevention is better than cure. So obviously you try to increase the intensity very slowly. But also it's important to have a strength and conditioning program that you focus not just on mileage and running the distance, but also at the same time complementing it with ensuring that your muscles are strong enough to handle the increased load and mileage that you're putting on it. Yeah, so that's the second one, Achilles tendonitis. Knee injuries, that's quite common too. Again, all those are all related to no limb. So patients who start running without much guidance and running too fast, too quickly, or too much too quickly tend to have pain in the knee. It has to be the front of the kneecap, and it's again quite common problem in runners, jumpers, athletes. And again, having a very structured training program, which includes strength and conditioning, and also the running form, is really important to prevent that. And usually most of these injuries can be treated without any surgery, and it's just a matter of preventing it and knowing when it comes and knowing when to hold back your training intensity and duration, because that's the only way you will find out with overuse injuries. Yeah.
Speaking of which, how do you determine soreness from running versus an injury?
Good question. Soreness from running, if you had a really tough session, you might be sore for 1 or 2 days. But I think when you have overdid like things and you have an injury, the symptoms or the pain, in this case pain or swelling, can persist for more than a few days. And that's when you know something has gone amiss. So that's how I separate the two. Although at the start it's usually a bit hard to tell.
If in that case, it links to our next question.
Yeah.
Is it safe to run if you have existing knee pain? If not, how do I go about managing the knee pain?
Yeah. So I mean, you talk about muscle soreness after a hard workout session. Usually, like I said, it usually goes off after 1 or 2 days. But when you have symptoms or pain that persists for longer than that, you might have injured something, and it's probably best to find out what you injured. And that's where hopefully I come in to try and help you with diagnosing your condition, finding out how bad the injury is, and whether or not you are safe to return to running. Again, there are different types of injuries, some obviously more serious than others. Overuse injuries tend to be less serious, and that usually can be treated with rest ice, compression, elevation of your limbs to reduce the symptoms, and also to take 1 notch down in terms of your training intensity, to let it rest for a while for the injury to recover and for you to get better. But if it's something more serious, then of course, it will be something that I would look into and advise you not to go back to running straight away, because you could make the injury worse by doing.
On a similar note, as we get older, as we mentioned earlier, running is generally good for you. But researchers have also found that if you run too much, especially those elite runners, elite ultramarathon runners, the chances of getting arthritis is higher when they age. At what point is the mileage too much?
Well, that's again a big question. I don't think the verdict is really out there that running leads to arthritis. But I mean, most people will come to me saying that if wear and tear is due to the use of your joints, like I said, isn't it logical to conclude that by running and putting your joints through more stresses, that will lead to more wear and tear? I don't think it's completely true. I think it's a balance, as in most things in life. But finding that balance is the million-dollar question. When we talk about ultra marathoners, we're talking about some probably it's not in the extreme scale. I think most of us wouldn't be in that category. And on the other extreme scale are those who are inactive or more sedentary. And I think it's that fine balance, a sweet spot where you do enough activity, because if you're on the sedentary side of things, you are probably going to have cardiovascular problems because of your lack of physical exercises, and you might have weak muscle, and that I think is worse for your joints than doing something at least to keep your joints active, to keep the muscles healthy and strong. So you just find that balance that you don't tip too much to just being sedentary, and that extreme whereby like you run. I mean, having said like those ultra marathoners, like, they still run no matter what. Like, so I mean, it is love it. It's just the passion that they have for the sport. But for most of us normal people, like it's really just find that balance between too much running and too little running. And I think only you can tell like what is your mileage that you think is suitable for you. Because everyone is different, and we all start at a different starting point. I mean, different points in our life.
Yeah, indeed. When we did our homework, the science does say that it's not going to lead to immediate pain or immediate wear and tear that you feel the pain for all these ultra marathon runners. It's later down the road. So indeed, it's a million-dollar question whether like you able to figure it out.
And I don't think we have research that shows that like, running really leads to accelerated wear and tear of the joints. I mean, there's no research that. I mean, I wish there was research that can show us that, but I think it's this. I mean, not all of us do ultra marathons, so I think most of us, it's just like that balance between being sedentary or being doing too much. So it's that sweet spot where you gotta get things right, and so that's where.
So maybe to understand the topic a little bit better, what are the causes of osteoarthritis?
Osteoarthritis is a medical term that means the joint is undergoing degeneration. Can be two major types. So this is going to be a bit technical. So I mean, there's the two types: primary and secondary. Primary arthritis is something that happens without any known cause. So this can be due to your genetics, could be due to your activity profile, and that leads to wear and tear of the joints. Secondary osteoarthritis is usually related to a cause. So if you had a previous injury to your joint, it will put you at a higher risk of wear and tear. And when I mean previous injury, let's say if you have a meniscus injury in your knee, because a meniscus is a shock absorber in your knee. When you have your meniscus injury, the shock absorber function is gone or reduced in your knee, and that leads to faster wear and tear in your knee joint. Or when you have an injury whereby there's a fracture, the bone is broken in your knee, and the surfaces are not as smooth as it used to. So just over the many cycles of the knee moving and rolling, that will lead to wear and tear, accelerated wear and tear in the knee joint. So that's the secondary osteoarthritis. So there are two types of osteoarthritis when we talk about osteoarthritis. And knowing the cause obviously would help us to determine what is the treatment options. But even for osteoarthritis, the prevention, again, I think it boils down to, again, I think when we're talking more about primary osteoarthritis, like really just ensuring that your muscle mass is strong, ensuring that you don't overload the joint. So when if you go into any sports or activity, to start at a certain baseline and to work up your weight, as opposed to doing too much too quickly, which is always a recipe for injuries. And keeping your body weight on the lower side too, that will reduce the impact and the load on the joint. So a few things that you can do to prevent, or I mean, you can't prevent it fully, but to slow down the rate of wear and tear in your knee.
In terms of primary and secondary, what are the difference in terms of solutions?
The solution, so in secondary osteoarthritis, let's say if you had your meniscus injury quite early on and before the wear and tear is really set in, there are options sometimes to repair the meniscus injury to provide that shock absorber function back in the knee. What some of the surgeons in the past did was to remove the meniscus entirely as part of the treatment for the meniscus injuries, and that has been shown to produce accelerated wear and tear, which is bad. So most of us nowadays, when we perform surgery to repair the meniscus, we will try and preserve as much as possible as opposed to removing it in order to preserve the shock absorption function. So these are things you can do if you have identified a certain problem early that you know would lead to wear and tear in the knee. And obviously, if you have a broken bone or a fracture, when we do the surgery to repair the fracture, we try and line up the surfaces of the bone as closely as possible so that they can reduce the irregularity in the surface to reduce the risk of that happening. But if you're talking about arthritis that has progressed quite far ahead, whereby we can't really tackle the cause of the arthritis, then it will be depending on the grade of the wear and tear arthritis, which again is a big topic.
Go ahead.
Yeah, I mean, if you're talking about early wear and tear, things that we can usually use to treat that would be minimally invasive things like injection of, we call it hyaluronic acid. It's essentially a substance that is naturally present in your joint as that lubrication. So that by injecting lubrication in the joint, it allows smoother gliding of the surfaces of the joint to reduce the symptoms you're experiencing. I don't think it takes away the wear and tear, but it just helps with your symptoms. There are also other injections that like PRP injection that is a bit controversial, but has been given into knees or joints that are arthritic to see if it helps. Those are the early stages of arthritis. But when it comes to later stages, they would usually involve some kind of surgery in the form of, in very advanced arthritis, there'll be a knee replacement or a partial knee replacement. There's only some part of the joint is worn. Or if patients are still very young and very active, there are options of joint realignment. So if your knee is a bit worn out on one side, we can actually tilt the bone to shift it to the other side so that the pressure now is on the good side. So there are a lot of options for patients depending on the type of arthritis they have, depending on the stage of arthritis they have. But all of us will always start up with non-invasive, non-surgical things, and only if things are really advanced and when the patients are very, very symptomatic, despite having tried all the non-surgical things, the surgery will be an option that we discuss closely with the patient.
Can you explain a little bit more about the decision framework between deciding on the injections as well as does someone go for both usually?
Most of us, I mean, again, it depends on the severity of the arthritis and depends on the patient's age. There are a lot of factors that come into play when we talk about the best treatment option for the patient. Let's have an example. So if a patient comes to me that is relatively young, in his 50s, 60s, we would always try the non-surgical options first. So like I mentioned, there'll be injections that can be in the form of the lubrication, injections in the form of biologics like PRP, and there are also options of knee braces that can offload, meaning that we shift the load in the knee to the part that's less arthritic. If it's not tricompartmental, meaning that the entire joint is arthritic, and of course, it's not going to help much. But if only one side of the joint is arthritic, then there are options of shifting or offloading that part that is arthritic. Braces, injections, medication, even simple aids like if you're an avid tracker, having a tracking pole to offload the knee. All these things are considerations to help patients who are not so keen on surgery at the start. And because as we know, like surgery also has its own risk as well, and it's not something that we offer patients straight away. So if patients have tried all this and things have not worked out, again, we have to look at the patient's age profile, because when we talk about knee replacement, there's usually a lifetime to the implant. So when you put in the metal implants to replace the arthritic joint, they too will actually undergo wear and tear. So on average, it's about 15 to 20 years for knee replacement before they need to be revised, meaning that like another surgery is done to replace that part that is worn out. So we don't normally encourage patients to have the surgery too early on unless they're really, really symptomatic and they've tried everything and nothing works. So the surgery options would be knee replacement. partially replacement for partial arthritis. And in patients who are a lot younger, who do not want any metal wear inside their joint and they want to preserve their original cartilage, it will be the realignment procedure to shift the load to the part of the knee that is less arthritic.
What are the complications between the three different type of procedures?
I think there are two main differences, like the knee replacements and the knee realignment. So knee realignment, we don't put metal to replace the surfaces. We just shift the bone in order to put load on the part that is less arthritic. For that surgery, it would involve cutting the bone and shifting it. Sounds really grim, but we do have to put metal plates and screws inside to hold the bone to allow it to heal. So there will be a period of downtime when you probably can't put as much weight on that leg to allow the bone to heal. So that would involve a prolonged period of rehabilitation. And for most patients, this is something that they have to be aware of, because it's not like after a surgery you can run a marathon straight away. There's actually a lot of time that is dedicated to the rehabilitation, especially for the knee realignment, because they need the bone to heal. There's also some risk of infection, nerve injury, non-healing of the bone, and as with most things, after a while, like even the knee realignment, it would eventually have problems because it still continues to wear and tear. It still continues to wear, but it's just that the part that's worn will be different. So you might need an eventual knee replacement in the future if things continue to progress. So that's the knee realignment procedure. When we consider knee replacement, now we are actually replacing the part that is worn out. We're putting metal prosthesis, metal implants into the knee. Don't have a model today, but we shave off the part of the bone, like the surfaces that are arthritic. We put in metal to replace those parts. And in between the two metal pieces, the tibia, the shin bone, and the femur, the thigh bone, there'll be a piece of plastic that is in between the two. And the risk, again, the general risk are infection, nerve injury. But now there's a risk of wearing out with the plastic implant. There's also a risk that you can damage and fracture the bone around the metal part, because now the bone is more fragile at the intersection between the metal implant and the bone. So these are the general considerations. But in terms of the rehabilitation, usually it's a bit faster for partial knee replacement and knee replacement. There's no restriction on how much weight you can put on the limb, as opposed to a knee realignment whereby you actually need the bone to heal first before you put more weight on the joint.
And just now you mentioned there's a shelf life, kind of.
Yeah.
What happens after the shelf life?
So when it's worn out, what we have to consider would be to revise the metal implants. And that would depend, again, on what has been put in. If it's a partial knee replacement, it will be likely to be a total knee replacement. So we actually have to remove the implants that are worn out and put back in implants. And it will probably be more complicated because the bone that is attached to the previous metal might come off with the implant that we remove. And that might need additional implants and additional complexity to the surgery. So the second surgery normally it will be a bit more complicated, but not super complicated, but a bit more complicated and a bit more consideration, which is why we normally don't tell patients to have the surgery until they've come to a point where they need it and they try everything else.
So another question I wanted to ask is, after the surgery, can you go back to your normal life, or are there complications?
I wouldn't say complications, but there are definitely some adjustments that you have to make after any surgery. Of course, the initial part after the surgery, the rehabilitation part, is the crucial one, that you ensure that our patients get back gradually to their active life. I mean, you wouldn't expect them to run a marathon straight after the surgery. You have to have a very good physiotherapist and a personal trainer who can really help you through the initial process, to guide you through, to take you through, in a very stepwise manner, and be able to advise you when to start doing more things. But by and large, I think most patients will get back to their sport of choice, but just, of course, with certain considerations and how to ensure that they don't injure it again, or to put too much stress on the implants and the surgical, the part that's been operated on.
So if you want to do a marathon of it, you can train.
There's nothing stopping you. Yeah, I mean, I have patients who have gone back to their previous level of sports. I mean, I can't guarantee that you will be able to hit that same performance, same personal best. But I think patients who are determined, they will go back to it. But just I think most patients do the surgery in order to be able to go back to their level of sports. So definitely, I don't think there's any reason why you shouldn't go back to your sports after surgery. When we do this so that you can go back to your sport.
Along the lines of prevention as well as solution, where does supplement play a role?
Good question, and something that I think a lot of the researchers in the world are trying to figure out, how much supplement can really contribute to prevention of arthritis or helping with arthritis. There are so many different products out there. You find like collagen, you find glucosamine, you find chondroitin. Those are the three most common ones that I always get asked by patients. The research is not really supportive that is better than placebo at the moment. But there is a bit of this mindset in patients that, they're not really keen for any surgery, they're not willing to take the risk for any surgery yet. So, taking the supplements, which usually doesn't really have any any bad side effects, and if it helps, why not? So, I think for them, there's not much risk in doing that. But I just advise caution, that they're mindful that it might not help that much. There's usually more placebo effect, more psychological. And unfortunately, there are some people marketing these products that were charged a premium price, an exclusive price. And I find sometimes that, it's not very fair for patients to be paying so much and expect that the supplements that they take are really as good as they make it out to be. So I think that's just my take on it.
Fair enough. Before we round off today's session, is there anything you want to add along the lines of OH, arthritis, running? Feel free to.
I just want to emphasize that you are never too old for running. I've met people who start running in their 50s, 60s, and not just for the competitive side of things, but it's something that they enjoy doing. And along the way, you meet the social part of running as well, groups that you run with, hang out with, and I think not just benefits for your physical health, but also for your social health, your mental health. And I would advise to really consider running if it's something that you have always been thinking of, but to be mindful that there are certain things, as a medical practitioner says, that you have to be medically fit and before you start running to ensure that you don't have any health problems that will arise from running. And if anything in life, to start slow and build up on your running mileage, distance, and your running intensity.
With that, we round off today's episode. If you have any questions, feel free to approach Jen. He has set up a new clinic
at Apex Sports Clinic.
If not, till next time, take care.